Welcome back, everyone. Today, we start our lecture with the continuation of factors affecting drug biotransformation from the last page. As we concluded previously, drug metabolism is influenced by many patient related and drug related factors. Enzyme induction. One important factor is enzyme induction. Certain medications increase the production or activity of drug metabolizing enzymes, particularly the cytochrome P450 or CYP450 system. This results in faster drug metabolism, lower plasma drug concentration, reduced therapeutic effect, and sometimes the need for higher drug doses. Some drugs induce their own metabolism, a phenomenon called autoinduction. For example, carbamazepine gradually increases its own metabolism over time. Phenobarbital induces CYP enzymes and increases the metabolisms of many drugs, including oral contraceptive pills, potentially causing contraceptive failure. Always remember that enzyme induction usually develops gradually over several days to weeks. Number two, liver dysfunction. Since the liver is primary site of drug metabolism, liver disease often reduces metabolic capacity. Examples include hepatitis, alcoholic liver disease, biliary cirrhosis, and hepatocellular carcinoma. Reduced metabolism causes drug accumulation, increased plasma concentration, and higher risk of toxicity. However, mild liver diseases may not produce major clinical effects because the liver has a significant reserve capacity. 3. Renal disease. Although the kidneys mainly eliminate drugs, renal disease can also decrease drug metabolism. This occurs because uremic toxins suppress hepatic enzymes. Metabolites accumulates and overall drug clearance decreases. Therefore, patients with kidney disease often require dose adjustments. Number 4, extremes of age. Age significantly influences drug metabolism. In neonates, immature liver enzymes reduced by transformation and drug remains in the body longer. In elderly patients, reduced liver mass, decreased hepatic blood flow, and lower enzyme activity. These changes increase the risk of adverse drug reactions. Interestingly, toddlers often metabolize certain drugs faster than adults because some metabolic pathways become highly active during childhood. Number 5, nutrition. Nutrition also affects liver enzyme activity. Poor nutrition causes protein deficiency, reduced enzyme synthesis, and a slower drug metabolism. Vitamin and mineral deficiencies may also impair enzymatic reactions. Therefore, malnourished patients often require careful dose adjustments. Number 6, alcohol. Alcohol has both acute and chronic effects. Alcohol ingestion temporarily inhibits CYP2E1, slowing metabolism. Chronic alcohol consumption induces CYP2E1. A clinically important consequence involves acetaminophen. Chronic alcohol users produce more of the toxic metabolite NAPQI, increasing the risk of severe liver injury, even at therapeutic doses. Number 7, smoking. Cigarette smoking induces CYP1A2. As a result, Smokers metabolize certain drugs more rapidly. Examples include theophylline and clozapine. If a patient suddenly stops smoking, drug metabolism decreases, potentially leading to toxic drug levels unless doses are adjusted. Drug excretion. Now let's move on the final phase of pharmacokinetics, excretion. The drug excretion is simply the removal of drugs or their metabolites from the body. The kidneys perform most drug elimination, although other organs contribute as well. Routes of drug excretion. Number one, kidney, the major route. The kidneys are the primary organs responsible for eliminating drugs. Overall, renal drug clearance depends on three processes: glomerular filtration, tubular secretion, and tubular reabsorption. Renal function. Kidney function is commonly assessed using serum creatinine and estimated GFR. Renal function naturally declines with age, approximately 7.5 milliliter per minute per decade, and decreases further in diseases such as diabetes. Patients with impaired kidney function often require lower drug doses to prevent toxicity. Processes affecting renal drug excretion. Glomerular filtration. Glomerular filtration is passive and energy independent. Only the free unbound fraction of a drug can pass through the glomerulus. Protein-bound drugs remain in the circulation. Drug filtration depends on glomerular filtration rate or GFR, the degree of protein binding, and the drug size. Higher protein binding means less filtration. Tubular secretion. Tubular secretion is an active transport process. Unlike filtration, both free drug and protein-bound drugs can ultimately be secreted because bound drugs dissociate as a free drug is removed. Different transporters exist for weak acids. Examples include penicillin, salicylic acid, probenecid, and chlorothiazide. Weak bases. Examples include quinine and metformin. Competitive for these transporters creates important drug interactions. For example, probenecid inhibits the secretion of penicillin, prolonging penicillin's plasma concentration. Number 3, tubular reabsorption. Some drugs are reabsorbed from the renal tubules back into the bloodstream. Reabsorption may be passive or active. Greater reabsorption means less drug excreted and longer duration of action. Factors affecting reabsorptions include urine pH, drug ionization, and lipid solubility. Stool or biliary excretion. Some drugs are secreted into bile and enter the gastrointestinal tract. Certain drugs undergo intrahepatic recirculation. Here's how it works. Number 1, drug is metabolized in the liver. Number 2, secreted into bile. Number 3, travels into the intestine. Number 4, gut bacteria convert metabolites back into the active drug. Number 5, drug is reabsorbed into the bloodstream. This recycling prolongs drug's action. Lungs. The lungs eliminate volatile anesthetics, inhaled gases, and vapors. These substances leave the body primarily during exhalation. Other routes. Smaller amounts of drugs are eliminated through sweat, saliva, and breast milk. Although these contribute little to the drug elimination, but they have important clinical implications. For example, rifampin appears in saliva. Many medications enter breast milk and may affect nursing infants. Pharmacokinetics considerations. Pharmacokinetics describe what the body does to a drug. It includes the four major processes summarized by the acronym ADME: absorption, distribution, metabolism, and excretion. These processes determine drug concentration, therapeutic effect, duration of action, and toxicity. Drug concentration over time is commonly represented using concentration versus time graphs. Time course of drug action. Many pharmacokinetic measurements are performed after intravenous administration because IV dosing avoids variability in drug absorption and provides immediate systemic availability. When plotting concentrations against time, pharmacologists often use a logarithmic scale, or log 10, to simplify calculations and visualize drug elimination. First order elimination. Most drugs follow first order kinetics. Characteristics include constant percentage eliminated per unit time. Elimination rate depends on drug concentration. Appears as a straight line on a log concentration versus time graph. Zero order elimination. A few drugs exhibit zero order kinetics when elimination pathways become saturated. Characteristics include constant amount eliminated per unit time. Elimination no longer depends on concentration. Appears as a curved line on concentration time graphs. Examples include ethanol, high-dose phenytoin, and high-dose aspirin. Hysteresis. Some drugs demonstrate hysteresis, meaning the same plasma concentration can produce different clinical responses depending on whether the drug levels are rising or falling. A classic example is warfarin, where anticoagulants effects lag behind plasma drug concentrations because time is required for clotting factor turnover. To summarize this page, drug metabolism is influenced by enzyme induction, liver disease, renal disease, age, nutrition, alcohol, and smoking. The kidneys are the primary organs responsible for drug excretion through glomerular filtration, tubular secretion, and tubular reabsorption. Drugs may also be eliminated through bile, lungs, sweat, saliva, and breast milk. Pharmacokinetics encompasses ADME, or absorption, distribution, metabolism, and excretion. Most drugs follow first-order kinetics, while a few demonstrate zero-order elimination under saturation condition. Understanding these pharmacokinetic principles is essential for selecting the correct drug dose, preventing toxicity, and optimizing patients' care. Now let's move on to the second page of today's lesson, of course. We start with half-life. One of the most important concepts in pharmacology is half-life. Half-life, written as T1 half, is the time required for the serum drug concentration to decrease by 50%. It is commonly called the elimination half-life. For most drugs, elimination follows first-order kinetics, meaning a constant proportion of the drug is eliminated over time. A clinically important rule is the 4 to 5 half-life rule. After approximately 4 to 5 half-lives, repeated dosing allows the drug to reach a steady state concentration. Similarly, after stopping a drug, about 4 to 5 half-lives are required for nearly complete elimination from the body. For example, if a drug has a half-life of 12 hours, it will reach a steady state in about 48 to 60 hours. And after discontinuation, it will also take roughly that long to be almost completely eliminated. This principle helps physicians determine when a medication begins producing consistent therapeutic effects and when drug levels become negligible after stopping treatment. A steady state drug concentration. Now let's discuss a steady state concentration. A steady state occurs when the rate of the drug administration equals the drug rate of elimination. At this point, the plasma drug concentration remains relatively constant despite ongoing dosing. Steady state concentrations are especially important when performing therapeutic drug monitoring because measuring drug levels before a steady state may produce misleading results. Certain clinical situations require special dosing strategies. The first is the use of a loading dose. A loading dose is administered when the drug has a long half-life or therapeutic levels must be achieved rapidly. Common examples include amiodarone, digoxin, phenytoin, and certain antibiotics. Without a loading dose, these medications may take several days to reach effective concentrations. Another situation involves continuous intravenous infusion. Continuous infusion is preferred for drugs with very short half-lives, a need for prolonged therapeutic effects, or when frequent repeated doses would be impractical. Examples include nitroprusside and unfractionated heparin and naloxone. Continuous infusion maintains a stable plasma concentrations while avoiding repeated injections. Clearance rate. Next is the concept of the clearance, abbreviated as CL. Clearance is a quantitative measure of the body's ability to eliminate a drug. More specifically, it is the volume of plasma from which a drug is completely removed per unit time. Mathematically, clearance equals the rate of the drug elimination divided by the plasma drug concentration. Clearance can refer to a single organ such as hepatic clearance by the liver or renal clearance by the kidneys. When no organ is specified, clearance refers to total body clearance, which represents the sum of clearance by eliminating organs. Another useful relationship is clearance equals elimination rate constant, or KE, multiplied by volume of distribution. Remember that elimination rate constant is 0.693 divided by the drug's half-life. Understanding clearance allows for clinicians to adjust maintenance doses, especially in patients with kidney or liver disease. Elimination kinetics. Drug elimination generally follows one of two patterns. First-order kinetics. Most drug follows first-order kinetics. In first order elimination, a constant percentage of the drug is eliminated during each unit of time. The elimination rate increases when plasma concentration increases. When drug concentration is plotted on the logarithmic scale against time, a straight line is produced. This predictable behavior makes dosing relatively straightforward. However, if elimination pathways become saturated, first order kinetics may no longer apply. Zero order or non-linear kinetics. A small number of drugs follow zero order kinetics. This includes classic examples such as alcohol, phenytoin, and high-dose aspirin. In zero order elimination, a constant amount rather than a constant percentage of a drug is removed each unit of time because elimination mechanisms become saturated. The concept of a constant half-life no longer applies. As drug concentration rises, even a small dose increases may produce large increases in plasma concentration, significantly raising the risk of toxicity. Many drugs display first-order kinetics at low concentrations but shift to zero-order kinetics after metabolic pathways become saturated. Because dosing becomes unpredictable, these medications often require therapeutic drug monitoring, drug-specific nomograms, and close clinical observation. Phenytoin and theophylline are common examples where careful monitoring is essential. Loading dose and maintenance dose. Now let's compare loading dose and maintenance dose. A loading dose is used when an immediate therapeutic effect is required. It is often administered intravenously to rapidly fill the drug's volume of distribution, particularly for drugs that distribute widely into tissues. Once therapeutic levels are achieved, treatment continues with a maintenance dose. The maintenance dose replaces the amount of drug eliminated from the body, maintaining concentrations within the therapeutic range. Importantly, maintenance dosing does not require a loading dose in most situations. Even without a loading dose, repeated maintenance dose eventually produces steady-state concentrations after approximately 4 to 5 half-lives. Maintenance therapy may be delivered as continuous intravenous infusion, although this is less common, or intermittent oral dosing, which is the standard approach for most medications. Pharmacodynamics. Having discussed what the body does to the drug, we now transition to pharmacodynamics, which studies what the drug does to the body. Pharmacodynamics examines the relationship between drug concentration and the biological response produced. It explains why different drugs produce different effects, even when they are present at the similar concentrations. Dose-response relationship. A key pharmacodynamic principle is the graded dose-response relationship. As the dose increases, the intensity of the drug's effect generally increases until the maximum possible response is reached. Initially, increasing the dose produces greater therapeutic benefits. Eventually, however, the response plateaus because all available receptors become occupied. At this point, giving more drugs does not increase efficacy, but does increase the likelihood of adverse effects. Efficacy. Finally, let's discuss efficacy. Efficacy refers to a drug's ability to produce the maximum biological response. It is measured by Emax, which represents the greater effect a drug can achieve regardless of the dose. A highly efficacious drug can produce a greater maximal effect than a drug with lower efficacy, even if both drugs bind to the same receptor. It is important to distinguish efficacy from potency. Potency describes how much drug is needed to produce an effect, and efficacy describes the maximum effect the drug is capable of producing. Clinically, efficacy is often more important because the goal is to achieve the desired therapeutic outcome. To summarize this page, half-life is the time required for plasma drug concentration to describe by 50%. Most drugs follow first-order kinetics and reach a steady state after 4 to 5 half-lives. Steady state occurs when the rate of drug administration equals the rate of elimination. Clearance measures the body's ability to eliminate a drug and helps determine maintenance dosing. Loading doses rapidly achieve therapeutic concentrations while maintenance doses maintain them. First-order kinetics eliminate a constant percentage of drug, whereas zero-order kinetics eliminate a constant amount. Pharmacodynamics studies the effect of drugs on body. Dose-response relationship describe how increasing doses affect therapeutic responses. Efficacy or Emax represents the maximum effect a drug can produce. Now let's move on to the next page and discuss the potency. Let's begin with potency. Potency refers to how much drug is required to produce a specific effect. It is measured by the EC50, which is the concentration of a drug required to produce 50% of its maximum effect, or Emax. If the dose rather than concentration is used, this value is called the ED50. A drug that reaches its EC50 at a lower concentration is considered more potent. Looking at figure 1, notice that drug A reaches 50% of its maximum effect at the lowest concentration, drug B requires a higher concentration, and drug C requires the highest concentration. Therefore, the order of potency is A greater than B greater than C. A useful way to remember this is the further left the curve, the greater the potency. Remember that potency tells us how much drug is needed, not how effective the drug ultimately is. Efficacy. Now let's discuss efficacy. Efficacy is the maximum effect a drug can produce, regardless of the dose administered. In figure 1, drug A and C both reaches the maximum response, or Emax. Drug B reaches a lower maximum response. Therefore, efficacy A equals C, which is greater than B. Notice that drug C is less potent than drug A because it requires a higher concentration. Yet, both drugs have the same efficacy because they eventually achieve the same maximal response. This highlights an important distinction. Potency equals how much drug is needed. Efficacy equals to how great the maximum effect is. In clinical practice, efficacy is generally more important because patients benefit from the maximum therapeutic effect, not simply from requiring a lower dose. Effects of the drugs on receptors. Drug effects occur when drugs interact with receptors. These receptors can act as either agonists or antagonists. Agonists. An agonist is a drug that binds to a receptor and mimics the action of the body's natural ligand, producing a biological response. Two important properties determine agonist activity. 1. Affinity. Affinity is the ability and the strength of a drug to bind to its receptor. For example, salbutamol has a greater affinity for beta 2 receptors than beta 1 receptors. So it binds preferentially to beta 1 receptors. High affinity means the drug binds more easily. Efficacy or intrinsic activity. Efficacy describes the ability of the bound drug to activate the receptor and produce a response. For example, when salbutamol binds to beta 2 receptors, it activates them, resulting in a smooth muscle relaxation and bronchodilation. Notice the difference. Affinity determines binding, efficacy determines activation after binding. A drug may bind very well but still fail to activate the receptor. Full agonists. A full agonist produces the maximum possible response once it occupies sufficient receptors. Examples include morphine and methadone. Both are full agonists at the mu opiate receptors, producing maximal analgesia. Partial agonists. A partial agonist binds to the same receptor but can only produce a partial response even when all receptors are occupied. It has a ceiling effect, meaning increasing the dose beyond a certain point does not increase the response. An important example is buprenorphine. Although it binds strongly to mu opiate receptors, it produces only partial receptor activation. This property makes buprenorphine useful in opiate dependence because it lowers the risk of respiratory depression. Antagonists. Unlike agonists, antagonists bind to receptors without activating them. Their role is to reduce or block the effects of agonists or endogenous ligands. There are several types of antagonists. Chemical antagonists, this occurs when the antagonist directly interacts chemically with the agonists. Instead of competing for receptors, it neutralizes or removes the agonists. Examples. Chelating agents bind heavy metals, allowing them to be eliminated from the body. Number 2, physiological or functional antagonists. Here, two drugs act on different receptors but produce opposite physiological effects. For example, insulin lowers blood glucose. Glucagon rises blood glucose. These oppose each other's effect without acting on the same receptor. Number 3, pharmacological antagonists. These occur when the antagonist interferes directly with receptor function. It can be divided into competitive and non-competitive antagonists. Competitive antagonists. Competitive antagonists bind to the same receptor site as the agonist, but produces no receptor activation, meaning they have zero efficacy. Reversible competitive antagonists. These bind non-covalently, so interaction is temporary. Because binding is reversible, increasing the concentration of the agonist can overcome the blockade. A classic example is naloxone, which competitively blocks opiate receptors and reverse morphine or heroin overdose. In figure 2, notice that increasing antagonists' concentration shifts the dose response curve to the right. The agonist requires a higher dose to produce the same effect. However, Emax remains unchanged and only potency decreases. This rightward shift is characteristic of reversible competitive antagonists. Irreversible competitive antagonists. These form covalent bonds with receptors. Once attached, they cannot be displaced. An example is phenoxybenzamine, which irreversibly blocks alpha-adrenergic receptors. Since receptors are permanently inactivated, increasing agonists' concentration cannot fully overcome the blockade. Figure 3. This figure illustrates irreversible antagonists. As antagonists' concentration increases, the maximum response decreases, and eventually, even very high agonist concentrations cannot restore the original effect. Unlike reversible antagonists, efficacy decreases, the loss of effect cannot be overcome. Non-competitive antagonists. Non-competitive antagonists bind to a different site on the receptor, known as an allosteric site. Binding changes the receptor's shape, reducing the agonist's ability to activate it. Even increasing agonist concentration cannot fully restore receptor activity because the receptor itself has been altered. To summarize this page, potency is measured by EC50 or ED50 and reflects how much drug is needed to produce an effect. A left-shifted dose response curve indicates greater potency. Efficacy is the maximum effect a drug can produce and is represented by Emax. Agonists bind and activate receptors, whereas antagonists bind without activating them. Full agonists produce maximal responses, while partial agonists have ceiling effect. Reversible competitive antagonists decrease potency but preserve efficacy because their effects can be overcome by increasing agonist concentration. Irreversible and non-competitive antagonists reduce efficacy by lowering the maximum achievable response. This page establishes the core principles of receptor pharmacology and provides foundation for understanding how different drugs produce therapeutic effects and how other drugs can block or modify those effects. Now let's move on our final page, page 4. Mechanism of antagonists and agonists. In figure 4, it illustrates the mechanisms of agonists and antagonists binding. Agonist binding. An agonist is a drug that binds to a receptor and activates it, producing a biological response. Think of the receptor as a lock and the agonist as the correct key. The sequence is straightforward. The agonist binds to the receptor undergoes activation, and this activation produces the desired physiological or pharmacological effect. Examples include salbutamol stimulates beta-2 receptors to produce bronchodilation. Morphine, activating opiate receptors to relieve pain. And insulin, binding insulin receptors to lower blood glucose. Remember, agonists have both affinity and efficacy. They bind to receptors and activate them. Antagonist binding. Unlike agonists, antagonists binding to receptors but do not activate them. The possesses affinity but lack efficacy. Their primary role is to block agonists from producing their effect. There are 3 major types. Number 1, competitive reversible antagonists. In a competitive reversible or antagonism, both agonists and antagonists compete for the same receptor binding site. Binding is reversible, and the antagonist can dissociate from the receptor. Since the antagonist can leave the receptor, increasing the concentration of agonist allows the agonist to outcompete the antagonist. Therefore, the maximum effect or Emax remains unchanged, and more agonist is needed to achieve the same response. Examples include naloxone competing with opiates, atropine competing with acetylcholines at muscarinic receptors, and propranolol competing with catecholamines at beta receptors. Number 2, competitive irreversible antagonism. Here, the antagonist binds to the same receptor site but forms a permanent or extremely stable bond because the receptor becomes permanently blocked. The agonist cannot bind, and increasing agonist concentration cannot reverse the blockade. Consequently, fewer functional receptors remain and the maximum response decreases. An important example is phenoxybenzamine, an irreversible alpha-adrenergic blocker. Number 3, non-competitive or allostric antagonists. In this mechanism, the antagonist binds to a different site called the allostric site rather than the antagonist binding site. Binding causes a conformational or a structural change in the receptor. Although the agonist may still bind, the receptor cannot become fully activated. Again, adding more agonists cannot overcome this inhibition. The maximal drug effect is therefore reduced. Figure 5. Agonist concentration response curves. Let's now examine how these mechanisms appear graphically. Graph A. Competitive reversible antagonists. The blue curve represents the agonist alone. Notice it reaches the maximum effect when a reversible competitive antagonist is added. The curve shifts to the right. This means a higher agonist concentration is required. Potency decreases and EC50 increases, and maximum efficacy remains unchanged. This rightward shift is the hallmark of competitive reversible antagonism. Graph B, non-competitive or irreversible antagonists. In the second graph, adding a non-competitive antagonist produces a different pattern. Instead of shifting to the right, the entire curve becomes lower. Even very high agonist concentrations cannot restore the original maximum response. Therefore, maximum efficacy decreases, potency may remain relatively unchanged, increasing agonist concentration cannot overcome inhibition. This is characteristics of irreversible or non-competitive antagonists. Clinical importance. Understanding these graphs is essential clinically. Ask yourself, can increasing the agonist dose overcome the antagonist? If the answer is yes, the antagonist is competitive and reversible. If the answer is no, the antagonist is likely irreversible or non-competitive. Effectiveness and safety. After understanding receptor pharmacology, let's discuss how we evaluate drugs clinically. Every drug must be assessed for two major characteristics: effectiveness and safety. Effectiveness. The primary measure is the ED50 or effective dose 50. ED50 is the dose required to produce the desired therapeutic effect in 50% of a test population. A lower ED50 indicates greater potency and less drug is needed to produce the desired effect. Safety. Drug safety is commonly evaluated using two measurements. LD50. The LD50 or lethal dose 50 is the dose that causes death in 50% of experimental subjects. This value is generally obtained from animal studies and is rarely determined in humans. TD50. The TD50 or toxic dose 50 is the dose that produces toxic effects in 50% of subjects. Unlike LD50, TD50 focuses on toxicity rather than mortality. Therapeutic index. One of the most important concepts in pharmacology is therapeutic index, abbreviated TI. It is calculated as therapeutic index equals TD50 divided by ED50. Or in animal study, LD50 divided by ED50. The therapeutic index compares the toxic doses with the effective dose. A larger therapeutic index indicates a wider safety margin, greater drug safety, and less risk of toxicity during normal treatment. A smaller therapeutic index means the effective dose is close to the toxic dose and careful monitoring is required. Drugs with a narrow therapeutic index. Several commonly used medications require close monitoring because they have narrow therapeutic window. These include digoxin, theophylline, warfarin, lithium, and cyclosporine. These drugs often require therapeutic drug monitoring or TDM to maintain safe plasma concentration. Factors affecting the therapeutic index. The therapeutic index is not fixed. It can change due to drug interactions, changes in absorption, distribution, metabolism, and exertion, or ADME, patient's age, pregnancy, liver disease, kidney impairments, or patient-specific characteristics. For this reason, clinicians individualize drug therapy for each patient. Certain safety factors. Another important safety measure is the certain safety factor, calculated as TD1 divided by ED99. This compares the dose causing toxicity in only 1% of individuals with the dose that is effective in 99% of individuals. It is considered a much stricter and more clinically meaningful measure of a drug safety than the therapeutic index. Regulatory agencies generally prefer drugs with a certain safety factor greater than 100, indicating a large margin between effective and toxic doses. To conclude this page, agonists bind and activate receptors because they possess both affinity and efficacy. Competitive reversible antagonists shift the dose-response curve to the right without reducing maximal effects. Irreversible and non-competitive antagonists decrease the maximal response, and their effects cannot be overcome by increasing agonist concentration. ED50 measures drug effectiveness. TD50 and LD50 measures drug toxicity and lethality. The therapeutic index, TD50 and ED50, estimates a drug's safety margin. The larger the index, the safer the drug. Drugs with a narrow therapeutic index such as digoxin, warfarin, lithium, theophylline, and cyclosporine requires careful dose adjustment and therapeutic drug monitoring. The certain safety factor TD1 ED99 provides an even more stringent assessment of drug safety and is often favored by regulatory agencies. Thank you for attending this lecture. If you're new to the channel, don't forget to